I'm Julie Graylow, Director of Breast Medical Oncology at the University of Washington and Seattle Cancer Care Alliance in Seattle, Washington. We'd like to show you an example of a tumor board, a breast cancer tumor board that we actually conduct twice a week in Seattle with our breast cancer patients who are newly diagnosed. Every Tuesday and Friday, we see 6 patients in our multidisciplinary breast cancer specialty clinic. We have a whole group of specialists in the room. So let's talk about who's in the room. We have our breast imagers who've already performed a lot of studies, as well as our pathologists to review all the pathology findings.
Our imaging workup began on November the 25th, 2015 with bilateral diagnostic mammography. The breasts are heterogeneously dense. The right breast is negative. In the left breast, upper outer quadrant posterior depth, there is an irregular mass, you see here outlined by the circle, with indistinct margins. She went on to have a diagnostic ultrasound of this area the same day. And on images labeled left 1 o'clock, 8 centimeters from the nipple, we see this irregular hypoechoic mass. It has indistinct margins. It measures 16 millimeters in maximum dimension. And images provided of the left axilla are unremarkable.
The biopsy of the left breast 1 o'clock mass had invasive ductal carcinoma, and prognostic markers taken at or performed at this time showed estrogen receptor, progesterone receptor, both strongly positive with already scores of 8. It was negative for HER2 by FISH. Subsequent biopsy of the left breast 2 o'clock was negative, and then the left breast lumpectomy had invasive ductal carcinoma, Nottingham grade 2 to 3.
We have surgical oncologists, medical oncologists, and radiation oncologists.
In summary, this is a 48-year-old woman who presented with a left breast clinically detected T2N0 upper outer quadrant invasive ductal carcinoma that is ER/PR positive, HER2 negative, Nottingham 2 to 3. She's been excised with clear margins and a negative sentinel node, so no further surgery is warranted.
Okay, so we would recommend left breast radiation for a 48-year-old, probably with conventional fractionation, with a 3 centimeter tumor and less than 50 years of age with a boost.
As far as what hormone therapy to give her, because she's had her uterus removed but not her ovaries, and she's only 48, we don't know what her hormonal status is. I didn't see any hormone levels in the chart, but we could draw some because that would push us in a direction of tamoxifen versus an aromatase inhibitor. There's always a discussion about if she were in the premenopausal range, would we add an LHRH analog? But I would have to say, I don't think that the SOFT trial that looked at that would support ovarian suppression in her case.
We have trainees because education and training is a big part of this tumor board. We have our whole clinical trials group because research and clinical trials are also a big part of our mission.
Gynecologic history, age of menarche was 15. She is G2P1. Her first pregnancy was at 18 years old. Menopause onset was about 45 years of age. She was on hormone replacement therapy with Premarin for about 8 years. Stopped that in her mid-50s, she believes, and she was on OCPs in her 20s for a total of about 6
Physical
years.
exam, notable for a heart rate in the 100s, which came down to the 80s by the time I saw her, as well as a BMI of 55. In terms of her breast exam, she has inverted nipples bilaterally, which she states has been present for as long as she can remember.
I also think that with a tumor less than 2 centimeters, she would have qualified for the APT trial, which is Taxol Herceptin for 12 weeks, followed by completion of a year of Herceptin and had excellent overall survival, disease-free survival. So I think that would be an appropriate regimen for her as well.
It's not difficult setting up a multidisciplinary breast cancer tumor board. The key is getting everyone in the same room and communicating, respecting each other's opinions, having dialogue about what the best possible treatment options are for a patient.
Can you comment on the discrepancy in size between the ultrasound of 16 millimeters and the MRI 3 centimeters, double? Just the way, is there anything in retrospect that makes you?
Not in the images provided to ultrasound, but commonly what happens is they take the easiest to find margins of the mass and they measure that as the greatest dimensions instead of trying to find that indistinct little arm that kind of slithers off into the breast parenchyma on an MRI, because in the subtracted views, everything else kind of goes away except for the enhancement. You get more accurate measures.
In retrospect, an ultrasound might have shown it closer to 3 centimeters.
Right, so for instance, on this image to the left up here, this mass could extend out to here if relevant.
We need to include tumor-specific factors, their pathology and their imaging. We need to include patient-specific factors in making the best recommendation. And we need to come up with a consensus recommendation that is based on state-of-the-art evidence and furthering research and education as well.